Thromboembolism risk. Okay. So one of the cornerstones of managing AFib is being able to understand and predict what's the stroke risk that's associated with it. And this is because that risk is significantly increased compared to patients without AFib. It's also because that AFib is responsible for about 1/4 of ischemic strokes in this country. And when you have a stroke that's related to AFib, it tends to be more severe and more debilitating. That means you're more likely to die from it or be left with a significant disability. There's also another significant proportion of ischemic strokes that also seem to be related to a distant site embolism into the brain. And there's quite a bit of research, and I'll talk about it in a little bit, that suggests that these are also originating from the heart without necessarily being associated with AFib as an arrhythmia, but more so with atrial disease. So how does this work? There's a thrombus that forms in the atrium, most commonly in non-valvular atrial fibrillation, and this is found in the left atrial appendage. And the brain itself receives about 20% of the cardiac output. So if you do the math, that's if there is a clot in the heart that embolizes out into the circulation, the likelihood of it ending up in a branch in the brain is higher than any other organ. Now, this association and trying to predict the risk has been with us ever since this relationship between AFib and stroke has been described. And there's been a lot of registries and trials trying to estimate that risk. So historically, there's AFI, SBAF, Framingham, ACC, American College of Chest Physicians. They all have tried to come up with scores and categorization of who's high risk and who's low risk and who's intermediate risk. So historically, we've kind of gone through a lot of these risk assessment tools and scores until we've reached to where we are today, where CHADS2-VASc is the most commonly used risk score. And you're all familiar with what CHADS2-VASc is, but this is a quick listing of what the components of it are. Things that are notable that are sometimes confusing are the points for congestive heart failure. This can be either systolic or diastolic, so clinical heart failure count. And if there are no signs of clinical heart failure, if somebody has a left ventricular ejection fraction that's depressed below 40, that also counts. Other points that are important are that hypertension, even if treated, also counts. And in terms of vascular disease, that means coronary disease resulting in an MI or a stent, or known peripheral vascular disease, including vascular disease going up to the brain or peripheral to other organs. And also the presence of plaque in the aorta. If somebody has had some kind of assessment of their aorta with TEE, for example, or CT, the presence of aortic plaque also counts as peripheral disease. The sex category is what's considered a risk modifier rather than a risk factor. So if you have a 55-year-old woman with no other risk factors and just has AFib, then practically her CHADS2-VASc is 0. Not 1. And if she's 65 or 67, then it's 1 + 1. So in of itself, the sex category is not something that conveys a higher risk, but in combination with another risk factor, it is a modifier, so it adds up to the risk. So the thing about these risk assessment tools is that you have to pick something that is easy to use and at the same time gives you this discriminatory ability to be able to tell who's high risk and needing to be treated and who isn't. So it's always a balance between practicality and accuracy. And a lot of the currently used risk stratification scores definitely favor ease of use, and they all suffer from a low accuracy. So a quick way to evaluate any test's accuracy is to look at this 2x2 table of presence of disease or absence of disease and positivity of the test and negativity of the test. And this is something that we do a lot in clinical medicine and evaluating sensitivity and specificity. And sort of a corollary to that, when you start looking at different cutoffs of various tests, you can start looking at the predictive accuracy of the tests. And this is something that you'll also often see evaluated with these curves called ROC curve, receiver operating characteristic curves, where the false positive rate is plotted on the x-axis and the sensitivity is plotted on the y-axis. And we're looking at the area under the curve of these various tests here. So the line of identity is the 45-degree angle here, where the test is really not really that helpful. And that's a area under the curve of 0, essentially. A perfect test is what you see in A, which is going straight up and straight across. And that has an area under the curve of 1. But most tests kind of fall in between. So as you get closer to A, the performance of your test gets better. And this is what historically all of these risk assessment tools have scored. So their ROCs have been really miserable. So this is AFI, SPAF, CHATS2, the Framingham score, the chest physician score. So the area under the curve here averages about 0.6 or something like that. For CHATS2 VASC, it's actually not that much better. So for patients with AFib, the C statistic, which is another measure of the ROC in this population, was 0.58. And in fact, the CHATS2 VASC performed better in patients without AFib compared to patients with AFib. So why is that? There are several factors that make these tests perform poorly. One of them is related to which populations you're looking at and their relative risk. Sometimes some other factors are related to mechanistic associations and why age or diabetes or high blood pressure contributes to the risk, something that is not completely and clearly understood. Sometimes the argument's made that these tests are not comprehensive enough. So yes, they're practical, but they are not looking at all of the factors, and maybe adding more factors will make the tests better. So let's look a little bit at that. This is the observed stroke rate in patients with atrial fibrillation across different cohorts studied. And I don't expect you to look at the fine print here and look at the various rates, but you can see that there's quite a wide range of observed strokes in these patients with atrial fibrillation, and these are events per 100,000 person years. And this is to make the point that the event rate is really dependent on which population you're treating, and the mix of different cohorts and different populations isn't always the same. There's been some suggestion, for example, that Asians have different risk compared to non-Asians, or there's been some examination across different other ethnicities, different countries, different risk factor profiles. All of these things play into these, and these cohorts come from different countries, different sources of data, different analysis groups. So making the point that your risk score performance will depend on which category of patients you're looking at. these are the components of CHADS2-VASc. There's an association between kidney disease and stroke risk. It's also associated with increased bleeding, but it's known to be a risk factor for increasing stroke. Family history also plays a role, and that's not represented in the risk scores. There's probably a genetic component to it. Race and ethnicity, I already mentioned to you. There are certain biomarkers that have been associated with stroke. There's the pattern of AFib that's also not captured in these risk scores. So specifically to that pattern of AFib, several studies now, large studies, have looked at the observed rate of stroke in patients with paroxysmal versus persistent versus permanent. And it's clear that those with paroxysmal AFib have a lower stroke risk related to their AFib compared to those with persistent or permanent forms of the arrhythmia. So it speaks a little bit also to the impact of AFib itself as a component of the many factors that lead to the clot formation and the impact of maybe a burden of atrial fibrillation on the stroke risk. There's also a similar signal that comes from treatment of atrial fibrillation, not so much in the AFFIRM trial. In fact, the AFFIRM trial, the patients who received drugs to control their AFib had a higher chance of discontinuation of their oral anticoagulants. So the stroke rate in the rhythm control arm was actually higher. In the ATHENA trial, actually, it was the opposite. So it was a composite endpoint that included stroke, and those patients in ATHENA that were treated with dronedarone for suppression of AFib actually had a lower composite endpoint. So something that is interesting, and data coming from ablation studies have also shown in these observational cohorts. This is data from Intermountain Healthcare, where patients who had undergone ablation were followed prospectively to see what the observed stroke risk was, and compared to counterparts without atrial fibrillation with similar CHADS2 scores, were shown to actually have a reduction in their stroke risk if they were to undergo ablation. And it was reduced to a level that was similar to a similar cohort of a similar CHADS2 score, but without AFib. So ablation and suppression of AFib does modulate the stroke risk. Does it reduce it enough to say that it's low enough now that treatment is not needed? These are studies that we still don't have answers to. A similar observation was also seen in the more recent AFNet-4 trial, where patients with diagnosed AFib within a year who were treated with antiarrhythmics mostly, some with ablation, and observed for mortality and a composite that included also stroke, were shown to have a reduction in that composite primary endpoint with early treatment of their atrial fibrillation. So another signal towards maybe suppression of AFib leading to reduction of stroke. Our largest trial that tried to address this was Cabana, and the answer was not available from the Cabana data because there was a high rate of continuation of anticoagulation in Cabana in both arms, the ablation arm and the drug arm. So there was no difference in stroke rate with these parameters. All right, this is still from East AFNet-4 here, showing the relative reduction in stroke in the rhythm control arm. Other things that I mentioned might also be contributory to the stroke risk in AFib are biomarkers. So these are several studies that were done out of a lot of these NOAC trials when they first came out. This is one of them examining troponin levels, and higher troponin levels were associated with higher stroke risks. Other studies that have looked at this, both in AFib and non-AFib patients, examined the role of BNP, and Chris Patton did one of these studies in the MESA population. So there's also something to be said about NT-proBNP and some biomarker relationship to that increased risk. After the CHADS 2 VASC score came the ATRIA score, which tried to capture some of these and tried to kind of parse out risk a little bit more. They created more categories with relation to age. They split patients into those who have had prior stroke versus not. They also incorporated kidney function measured through EGFR. So you got another risk point for EGFR less than 45. They also added proteinuria into there. And as you can see, this makes it a little bit harder to use because it's just harder to remember all of these things. And you also need to look at blood work and proteinuria and all of that. Unfortunately, the improvement as far as that ROC with the ATRIA score was not that dramatic. So still kind of stuck with where we are right now as far as stroke risk prediction. Other ideas that have come up have focused on the fact that we really still don't quite understand how thrombi form in the left atrium and the left atrial appendage specifically. There are several factors obviously related to some form of the Virchow triad of stasis and hypercoagulability and tissue injury. This has not really been proven in the atrium, but a lot of these extrapolations from vascular beds elsewhere have been used and extrapolated to the appendage and clots that form there in the setting of AFib. There's some evidence that supports that some of these mechanisms are coming into play, including blood stasis with some reduction in contractility, increase in stasis within the left atrial appendage, and this has been shown with flow modeling and flow studies looking at blood flow in and out of the left atrial appendage, and I'll show you a little bit more about that. There are also some biomarker studies as far as anticoagulation and procoagulant factors, including D-dimers and thrombin antithrombin complexes, and studies that seem to suggest that there is activation of procoagulant factors in the setting of atrial fibrillation. Tissue, on the other hand, endothelial injury is hard to assess within the left atrium. There's a lot of work that's been done on fibrosis within the atrial wall and injury that way and replacement. The endothelium itself, not so much. There are some biomarkers that have looked at endothelial injury that also suggest the presence of inflammatory factors and some evidence of platelet activation and endothelial factor activation. The level of evidence has been relatively restricted to smaller studies or animal studies, and no global mechanistic explanation for all of this is available as of yet. Then there's this concept of atrial myopathy or atrial cardiomyopathy that was introduced a few years back and continues to evolve and get better defined as far as the role of changes in the atrium itself that lead to rhythm abnormalities, function abnormalities, and as a result of the contribution of both of these, increase in the risk of thrombus and thromboembolization. Other measures of atrial factors that have relied on imaging have looked at changes in the shape of the atrium. So this is a study that was done by Felipe Bisbal, who looked at CT scans and MRIs and imported them into actually our cardio mapping system, and tried to get a measure of how spherical the left atrium is. So as you see on the top panel, the atrium is more or less like a disc or a discoid, sort of a red blood cell shape, which is what we normally see in a normal left atrium. But as that atrium starts to remodel and the volume starts to increase, it becomes more and more spherical. So this is one of the things that you've probably heard me talk about in terms of volumetric changes and remodeling at the level of the atrium. So the more spherical the atrium, there's been an association with an increased risk of stroke in that setting. The same measure actually Felipe studied in ablation outcomes and showed that ablations also are not as successful the more spherical the atrium is. Other things that we've been focused on in terms of atrial fibrosis and using cardiac MR have also shown an association between atrial fibrosis and stroke in these patients with AFib. The higher the fibrosis score, the more likely that those patients have either historically had a high risk of, have either historically had a higher likelihood of having had a stroke, or in prospective analysis, a higher chance of incident stroke. This is also related to atrial function, and I was chatting with Tomio yesterday about what's a normal global longitudinal strain, and even for the ventricle, this is still not clearly well defined, even especially across different vendors. So there's a little bit of work to be done as far as defining it for the atrium, but it is available. And when we did the study looking at strain and strain rate, there is an association between reduction in atrial strain and the level of fibrotic involvement in the left atrium. When we looked at the association of the atrial fibrosis with transesophageal echo studies, where we looked at thrombus formation and presence of thrombus, not formation, there's also an association between the presence of thrombus and the degree of fibrosis. So the higher, there's higher fibrosis in those patients with thrombus compared to those with spontaneous echo contrast, compared to a clean, no contrast and no thrombus atrial appendage. And this actually has helped improve the predictive ability of our classic measures. So if you take CHAS2-VASc and you add the AFib type and what level of anticoagulation those patients were, and try to predict who was going to have a thrombus or a spontaneous echo contrast on their TEE. The initial model's area under the curve was 0.67. Once fibrosis was added into the picture, the area under the curve improved significantly. And in terms of statistical associations, there was no known or statistical relationship between fibrosis itself and the CHAS2-VASc and the other components of that model. Quick word about device-detected arrhythmias and the issue of temporal dissociation between arrhythmia episodes and thromboembolic episodes. So this is an observation that's been with us now for several years, and it's cast some doubt about the role of AFib itself in thrombus formation, and sort of pushed us towards a different way of thinking about this that puts atrial disease kind of at the center of this association, where the atrial disease can be associated with AFib and therefore be associated with thromboembolism and stroke, but it can also be associated with thromboembolism and stroke without necessarily going through that atrial fibrillation step. So this approach, or this sort of way of thinking about the problem, has been supported by other findings that especially have been studied in patients without known atrial fibrillation, but with these cryptogenic or embolic stroke of undetermined source, that have shown strong associations between atrial function and embolic stroke, but without the presence of atrial fibrillation. So sort of the new paradigm of thinking about this, as I mentioned before, is that there are several factors that lead to atrial disease. That atrial disease in the presence of arrhythmia triggers can lead to arrhythmias, but it can also lead to thromboembolism if there are clotting triggers without necessarily having the arrhythmia itself. There's also this relatively new concept of what's called atrial failure. This is something that Felipe also worked on in collaboration with other investigators, and published this in JACC a year ago, where he tries to describe different ways where the atrium can fail that may not all be related to arrhythmia. So there's atrial dysynchrony, atrial contractile function, atrial reservoir function, and conduit function that all can be affected, and they don't necessarily need to coexist, and they manifest with different ways. This is some of the work that we've been doing in this space, where we are also have looked at the role of atrial fibrosis and the volume of blood that's ejected out of the atrium, or the volumetric changes within the atrium itself in a cardiac cycle. So on the orange curve, when we model that volume in an atrial cardiac cycle, you can see what the area under the curve is here. This is change over time, obviously. In the blue curve, when we add fibrosis, we can demonstrate that this actually does impact the contractility of the atrium. So there's definitely something to be said about that and its role in the pathophysiology of thrombus formation. The other important work that, sorry, I missed adding the reference here. This is work that is led by Juan Carlos del Alamo. Sorry, I must have been a white font or something that I copied onto this slide background. The work done here examines residence time, so blood flow in and out of the atrium and left atrial appendage in particular. And the higher the residence time of blood within the left atrial appendage, the higher the risk of that blood clotting. So lots of studies in this area that have looked at the association of blood residence time in the left atrial appendage have shown that the higher the residence time, the more likely to find a thrombus in there. And this is ongoing work. This is something that we are working on as a major area of research for us, where we're trying to mechanistically understand how these factors interplay, tissue changes caused by fibrosis, how they interplay with electrophysiological changes, inducibility of atrial fibrillation, and electromechanical dysfunction, and then adding all three together and trying to understand how that also impacts that fluid dynamics model and thrombus formation in the atrium, in the hopes that we can actually be able to predict with more accuracy in a mechanistically based fashion which patients are likely to show arrhythmia, which patients are likely to show thrombus, which patients are likely to show both, and what's the best approach to managing these patients. So if you'd like to read more about how we are thinking about this, this is a white paper that we published in Heart last year that goes over some of these concepts, and we're looking forward to more research in this area, hopefully. with a favorable funding score. Now, switching gears a little bit to the other side of managing this equation, which is the bleeding side. So every time we think about trying to reduce stroke risk and thinking about putting somebody on a blood thinner, we also have to think about what is their chance of bleeding on that blood thinner, and try to estimate that. So there are different scores that are also out there in terms of trying to estimate the bleeding risk. Has-bled is the one that's easiest to use, and there are others out there, including actually Atria and CHADS2-VASc that have been studied in terms of bleeding risk estimation. But has-bled includes age, same as the CHADS2-VASc. Hypertension in this case needs to be out of control, so systolic more than 160. The presence of abnormal kidney or liver function. So recall also that abnormal kidney function is also a risk factor for stroke. Abnormal kidney function here is creatinine more than 2.5. Prior stroke increases the bleeding risk. Prior bleeding increases the bleeding risk. For patients who are on warfarin, having a labile INR also increases the bleeding risk. And drug or alcohol use also increases the bleeding risk. So drugs like aspirin increase the bleeding risk, and you get a point for that too. So a lot of shared risk factors, and a lot of times this is kind of reflected in a lot of patient managements, especially with those with AFib and prior bleeding, where we're kind of stuck. If we treat them, we might be accepting a high risk of bleeding, versus if we don't treat them, we're accepting a higher risk of stroke. Now, I'm going to talk a little bit in the next section about what are our options in terms of reducing stroke risk, and warfarin, largely for historical perspectives, has been important to look at. Now, a new patient with atrial fibrillation is significantly more likely to get started on a NOAC rather than a warfarin, with rare exceptions like mechanical valves or some other indication for anticoagulation where the NOACs have not been studied, or rarely these days for insurance issues. But warfarin has always had the problem of a narrow therapeutic window, where the bleeding risk goes up significantly when you get out of the 2 to 3 range, and the efficacy goes down significantly when you go below 2. So warfarin works, as you know, in blocking several of these clotting factors, 2, 7, 9, and 10. And where the new agents come in are in blocking 10A. So all of the XA drugs, apixaban, rivaroxaban, and edoxaban, block 10A, whereas the bigatran is further downstream, and it blocks 2A, or thrombin. So just also to give you a historical perspective, in terms of clinical trials that have looked at the efficacy of these agents, back in the day where warfarin was kind of our workhorse in this population, the number of patients included in randomized trials was relatively small compared to what the more recent trials have enrolled in this population. So cumulatively, about 3,000 patients studied against placebo in the warfarin era, and then a lot of clinical experience, observational data with warfarin for several years. And then with the NOACs, a lot of these trials, Rely, Rocket, Aristotle, and Engage for the bigatran, rivaroxaban, apixaban, and edoxaban, respectively. Cumulatively, the number of patients that were enrolled were much, much higher, and they were all compared to warfarin. So in AFib patients, and all designed for non-inferiority. So quick comparison between the two, also for historical reasons: slow onset for warfarin versus rapid for the new drugs. So for most of them, if you give a patient a new oral anticoagulant or DOAC, you expect them to be therapeutically anticoagulated after a couple of hours. Whereas with warfarin, it takes time, and you know how long it takes for the INR to go up. Fixed doses versus variable, drug interactions, food interactions, many versus few with the new drugs. No need for monitoring except baseline kidney function, BNP, and yearly after that, whereas the frequent INRs with the warfarin. Another thing that's important to note about these DOACs is that the population that was studied was different between the 4 drugs. And what I mean by different is that they differ by their baseline risk. So if you look at the pies at the bottom, the breakdown of which patients had a CHATS 2 of 0 to 1 versus 2 versus greater than 3 vary significantly between these 4 agents. And this is also reflected in their outcomes. So especially when it comes to stroke and bleeding. So apixaban and the dabigatran, or the dabigatran at 150 milligrams, are the 2 that actually had a reduction in stroke risk, and rivaroxaban and edoxaban didn't. The other important things to look at are bleeding, and that's hemorrhagic stroke and GI bleeding. So you do see a signal for increased bleeding, for example, in rivaroxaban, but you also have to remember that, going back to these pies, with rivaroxaban, there are a lot of blues here. So 87% of the patients had a CHATS 2 VASC of 3 or more, compared to apixaban, which had only 30% of these patients with high risk. And as I showed you before, the same risk factors that increase the risk of stroke also increase the risk of bleeding. So these drugs have never been compared head to head. So you have to kind of look at the data and take it with a grain of salt in terms of trying to estimate bleeding risk and stroke risk. You have to really look at the baseline risk for each when you're looking at a particular patient. These are the dosing ranges for these drugs. More recently, apixaban and Riva, I think, have gained FDA approval for use even in end-stage kidney disease patients. And this is driven mostly by a lower risk of bleeding in those patients compared to warfarin. So that's where things stand there. I also wanted to touch on a little glimpse of the future here in terms of anticoagulants. There's a bunch of clinical trials that are currently ongoing where the role of factor 11 is being examined. And I don't want to go over the coagulation cascade again, but there's the extrinsic and then the intrinsic pathways, and the triggers for starting a clot are different between the two, and the resultant effect can be hemostasis versus a stronger drive to generate a large clot that sometimes can be occlusive or cause a DVT or an arterial thrombus or a clot in the left atrial appendage. So studies around this issue of hemostasis versus thrombosis have revealed an important role that factor 11 has in terms of these two mechanisms. So it seems like factor 11 and the sort of intrinsic versus extrinsic here are much more involved in creating a thrombus as opposed to a reaction to a tissue injury that only requires hemostasis to occur. So the effect of these various anticoagulant options that we've talked about. We didn't talk about heparins very much, but heparins actually treat both. So you do prevent clots, and you also affect the clotting that results in hemostasis. So therefore, as you're trying to prevent clots, you are also taking on a relatively high risk of bleeding from lack of hemostasis. Same thing with VKAs, so vitamin K antagonists, which block all of these factors that I told you about, where you do inhibit clotting, but it's also at a high price of increased bleeding due to the effect on hemostasis. This effect is still present with DOACs to a lesser degree, so there's still a bleeding risk that's associated with DOACs. But there are currently ongoing studies looking at inhibiting factor 11. And this seems to at least promise to show a much clearer separation between that clotting versus thrombus formation versus a hemostasis effect. So it appears to be more ideally suited for preventing thrombi without interfering with the hemostasis process, and hopefully will be associated with less bleeding in the future. So stay tuned for that. The last 10 minutes or so that we have, I want to talk a little bit about appendage occlusion, also as an option to mitigate the risk of thrombus formation and stroke and atrial fibrillation. So what you're seeing here is the Watchman device. This is what's referred to as Watchman 2.5, so the older version of Watchman. These devices were introduced around 2015 after FDA approval. They've been in clinical studies prior to that, with Prevail and Protect being the prospective trials, and a lot of registry data that ultimately led to FDA approval. FDA approved them as an alternative to oral anticoagulants without really much more specificity to that. Later, more details were added when, as many things in our business, we have to worry about insurance and who pays for this. So when CMS made a decision on which patients they wanted to cover for this option, they stipulated more things like a CHADS-VASC 3 or more, and a shared decision-making conversation with members of the team that are not implanting the device, et cetera. So trying to put some limits on who's really a candidate, at least who they will pay for to get this device. So this is a schematic of how these things work. So it's a catheter-based deployment of the device. Transseptal puncture is involved to get into the left atrium. The catheter is directed towards the left atrial appendage. And the device itself is actually all prolapsed inside the catheter. So as you pull the catheter, you unsheath the device and it kind of springs into the shape that you want to deploy at the opening of the left atrial appendage. And if you're happy with the position, and this is guided by imaging, most commonly transesophageal echo, then you release the device. So you unscrew this wire that's holding the device, and then it stays there. And this is what's supposed to happen with time. So as the device is sitting there, the blood that goes in to the appendage and eventually will clot there will not be able to get out. So the flow in and out of the appendage will cease. And then there's endothelialization, and the device is covered with endothelial tissue, so that whole appendage is excluded from the circulation. The results from the various trials and registries were, the two endpoints that are important in this option are: is the device good enough to protect against stroke, and is the device safer from a bleeding perspective? So the trials were designed as such, so they were non-inferiority trials, and the stroke reduction was non-inferior in those who got Watchman compared to those who got warfarin in Prevail and Protect. With time, there was a reduction in the bleeding, hemorrhagic stroke. The thought behind that is that when those patients are able to come off of their oral anticoagulants, then that's associated with a lower bleeding risk. Those patients will continue to be on aspirin long-term, so there's not an elimination of that bleeding risk because aspirin itself carries some risk of bleeding as well. They've been also compared, also in a non-inferiority model, to the DOACs. This is a relatively small study, but it was a randomized trial of Watchman versus apixaban in this case, and also met that non-inferiority comparison of equally protecting against stroke, and bleeding was not significantly different in this population that was studied here. Now, one of the things that we always worry about with this option, with this device, is thrombus that forms despite the presence of the device. And this is often a thrombus that is on the device itself, or device-related thrombus. And it's pretty worrisome to see this. And a lot of times these patients will end up back on their oral anticoagulants to try and dissolve this thrombus and reduce their stroke risk. So what's the rate of device-related thrombus? It's in this cohort from registry data, the incidence of it was about 3.7%. So it's in that range, somewhere between 3% and up to 5% in some other cohorts. The patients who do have a device-related thrombus have a 3 times increased risk of stroke compared to those who didn't have it. No surprise there. Predictors of device-related thrombi include prior history of stroke, permanent AF, vascular disease, larger AF, atrial appendage diameter, and a lower left ventricular ejection fraction, again, in this particular cohort that's studied here. Larger cohorts have also looked at this, and this is now registry data from the Evolution registry. This is a largely European registry of patients who got that first generation Watchman device. And it's a registry, so there's no mandate to what protocol these patients were on after the device went in. So some of them followed that 45-day anticoagulation and aspirin, and then switched to DAP, then switched to aspirin, but a lot of them actually didn't. So as you can see from these bar graphs here, the post-implant, for example, here, only 27% were on oral anticoagulant, 60% were on DAP. And those percentages decreased over time, and a lot of shifting happened towards single antiplatelets. And then there were not an insignificant proportion were on nothing in long-term follow-up. DRT, or device-related thrombus, in this registry, which was about 1,000 patients, was surprisingly similar in those who were on NOAC versus DAP versus single antiplatelet. But none of this reached statistical significance, so take it with a grain of salt in terms of the role of the various anticoagulation options in this population, or maybe other factors that may not be related to the device itself, that may be related to prothrombotic state. And they may also be related to the way the device is sitting, and how much metal is exposed, etc. So lots of questions are still unanswered there. With the time running out, and I apologize for starting late, I also want to mention sort of what's new in this space. If you were going to get a Watchman device now, you actually won't get that older Watchman. There's now a new generation of that device called Watchman Flex. And this is by design different than the older Watchman. So you can see that the device itself is shorter, and the exposed metal on the bottom is less. So that skirt of mesh that is on the crown of the device goes down further. The way the device anchors itself is also different. There are more anchoring tines on the Watchman Flex. The support of the device itself is also different. So there are 18 different struts on the new device versus 10 on the old. That gives it more ability to flex its shape and conform to usually an oval surface at the opening of the appendage. The other difference is that the dome of the device where the wire attaches, where this, it's called the threaded insert, the exposed metal is significantly less with the newer Watchman compared to the old. So when this device was compared to the historical device, there was a reduction in these endpoints of safety. It seems to be promising in that newer technology, newer design of the new device seems to be better. In terms of DRT, it also suggests that it's also going to be better, but it's not completely eliminated. So you can still have a device-related thrombus with a Watchman Flex, but much less so compared to the old Watchman. And quickly also telling you about sort of the more recent kid on the block, which is another appendage occlusion device called the AMULET. The AMULET is shown here in the top left, where you kind of have two layers of obstruction. You have the device that's anchored there, and then you have another sort of platform that helps keep the device in place that's more on the atrial side and covers more of that opening of the left atrial appendage. So the AMULET IDE trial compared that new device, which is made by Abbott, to the old Watchman. So this was a randomized trial that was presented recently at the European Society of Cardiology Congress, with several safety and efficacy endpoints examined. The other important thing about this new device is that most patients were discharged on antiplatelet agents only when they went home, whereas with Watchman, most of them went home on an oral anticoagulant. In terms of the safety and efficacy endpoints, there was no significant difference between the two options. When they looked at the occlusion of the appendage and whether there was a significant leak or a space between the device itself and the wall of the appendage, so is there still a channel of blood that can still go in to the appendage, there was statistically slightly more of these in the Watchman compared to the AMULET, also related to the design of the device. But the rate of leaks that were significant, or more than 5 millimeters, was very, very low. The other thing that was different between those two is that procedural complications were higher in the new device, and it may be related to the fact that it was new, and people need just more practice with it. So it's an interesting option to have, especially for patients that are not good candidates for oral anticoagulation, even for that 45-day period right after the device is implanted. A smaller study was just presented at TCT, compared this AMULET device to the Watchman Flex. So the AMULET patient arm had 111 patients. The comparison arm, 85 Watchman Flexes and 25 Watchman 2.5s, which is the older Watchman device. This study also was interesting in that it looked at the occlusion of the appendage with CT scans rather than TEEs. And they looked to see whether there was contrast going into the appendage and whether it was going through the device or next to the device. But the primary outcome of occluding the appendage was similar between the two. And the difference was that there was, again, noticed even in a smaller cohort, a higher likelihood of device or the procedure-related complications with the AMULET device compared to the Watchman device. We also, I don't need to spend too much time on this, have to mention the surgical option. So there are patients with AFib here that were studied, that were going for cardiac surgery, and they were randomized to get their appendage sewn over versus not. Both arms were continued on oral anticoagulation, and the observed stroke risk and follow-up in these patients was 4.8% in that appendage over sewing arm plus anticoagulation, 75% of the patients, compared to 7% with an anticoagulation continuation rate of 78%. So speaks to the role of the appendage, but also speaks to other non-appendage related sources of thrombus and embolization in these AFib patients undergoing surgery. So last slide. So risk prediction is not easy, and the clinical risk scores that we have at our disposal are imperfect. Mechanistic studies trying to understand this better are ongoing, and this is very exciting, and we're happy to be very much active in this space. DOACs continue to be the mainstay of prevention in this day and age. Look out for factor 11 inhibition. Seems to be promising and might change the landscape as far as bleeding associated with these DOACs. And left atrial appendage occlusion is an alternative for all anticoagulants in the appropriately selected patients. And thank you for your attention.
Thank you. That was wonderful.
Thank you, Bishoy.
Thanks, Nazem. I'm
Yep.
curious if you have any thoughts about some of the alternative things we hear about sometimes, like lariat or the AtriClip for surgery versus oversewing.
Yeah, I didn't put them on there, but these are definitely options out there, and the amount of data that's out there to support them probably not as robust as the other options that I mentioned. Particularly curious about lariat. I'm sure you saw the results of the AMAZE trial. This was mostly to look at AFib outcomes after ablation plus excluding the appendage, and it was disappointingly also not showing any superiority. We don't know what's the outcome from a stroke perspective in that cohort, but to me, they're definitely more on the invasive side, and I just don't know if, especially with the oversewing trial with continuing of oral anticoagulants, if it's for all the patients. Maybe for some who, you know, a difference in stroke rate between 7 to 4.8, if I'm remembering the percentages correctly from that surgical oversewing study. Maybe for some patients, it may be worth it to do it and stay on oral anticoagulant, but it's just a very tricky decision to make, especially with the morbidity involved with trying to do these procedures.
Makes sense. Thank you.
Have a great day.
All right. Thank you all.